Okay, thanks. Hi, everyone. I toyed around a lot with the title for this and the picture. I must thank my father for two things. One, he was actually the one who made me aware of global events and that polio had been picked up in a child in Gaza. So the horror of that, and he told me about that and was saying, how on earth are they going to manage that now? And he also helped me get the AI image of this because I wanted something showing children versus polio and the vaccine on our side, but it's a tug of war between people and polio, and it seems polio is still getting the upper hand. Great. Okay. So why I talk about polio, I was allowed to choose anything I wanted. So I thought the story of polio it piqued my interest. That's a pun on a peculiarities. It piqued my interest greatly. There's quite a few peculiarities about this disease I discovered as I read more. The people, politics, and persecution that have played a huge role in our ongoing battle to eradicate it. The story involves some pertinent people. We might have thought it was gone, but it keeps popping up. It's a pediatric disease, often and usually, and certainly at the beginning, although it affects people for the rest of their lives, and I am a pediatrician. There's the aspects of the EPI, which I certainly find confusing and have for many years. So I thought it was good to peruse it thoroughly. And up until now, I must say I've known precious little about it. So I'll be honest, up until now, I kept wondering, is polio eradicated? Isn't it? Why do we keep hearing about it? But it's not really here. We never see it. And I think it depends on our age, but since most of the polio happened up until sort of the 1950s, there might be people who grew up either maybe even with polio or a family member with polio, or you knew an older person in your family who has polio, but we very seldom certainly see it I haven't seen polio coming in as an acute case when I've been a practicing doctor or a student. And I knew that it caused atrophied limbs, which were usually someone's legs, and it could cause chronic pain and a lifetime of difficulty. But yeah, like I said, I've never seen an acute case of polio, and all I know is that we have to notify all cases of acute flaccid paralysis, which is just really, I've always thought, just a pain, because we usually think the patient has Guillain-Barré more than anything when we see a child with leg weakness. And then we have to fill out these forms that say, please send stool, and the child never gives us stool. We can't get stool from them, and it just seems a pain. But now I see the importance of it all. So I wanted to get some facts about the virus and the disease out of the way before we get into the really interesting stuff. It belongs to the family Picornaviridae, which actually is an acronym, the picorna part, but it also means small. So they are small viruses. It's part of the genus Enterovirus, and the species is poliovirus. And of that, there are 3 serotypes, 1, 2, and 3. They have names, but I don't really think it's worth knowing them. Not for me anyway. And that's based on their different capsid proteins. They vary slightly in their ability to cause, in their virulence. So type 1 is the most likely to cause paralysis. As for type 2, it was last detected in India in 1999 and declared eradicated in 2015. That's the wild type poliovirus 2. And then type 3 was last seen in 2012 and declared eradicated in 2019. It's related to rhinovirus, and if you've ever seen a PCR result saying enterovirus/rhinovirus, that's because I think on the PCRs they're similar, so although you would think there's nothing close about them. It's a small non-enveloped RNA virus, which basically to me means they're harder to kill with alcohol and detergents, because that gives them almost some vulnerability, the envelope. So these don't have an envelope. And humans are the only natural host of poliovirus. It can infect mice and non-human primates in a laboratory setting, but it doesn't exist like this in nature. And it is a highly infectious virus. The spread is fecal-oral, which can be person to person, so actually stool on someone's hand or something, touching someone else's face, getting into their mouth, or it can be via water or food contaminated with the virus, and actually also oral, or by coughing and sneezing, because it may be present in the nasopharynx for a little while when someone's infected. So this gives quite a few ways of transmitting this virus. And people, unvaccinated people can shed the virus for 3 to 4 weeks once they've been infected, and up to 6 weeks in the stool and in the throat for up to 7 days. And one is infectious up to a week prior to the symptoms if they do become symptomatic. And you can certainly be shedding it even if you're asymptomatic, which most people actually are. So a little bit like COVID, that you spread it without knowing you're even sick. The virus can survive in soil, in sewage, and contaminated water for up to a few weeks. So the immunity that is induced from infection results in both IgG and IgA, as well as cell-mediated immunity in the gut. And that IgA and IgG is specific to the infecting serotype, and after an infection, this is lifelong immunity. And yeah, okay, and this mucosal immunity is what decreases shedding if the polio virus is encountered again. So we really do count on this mucosal immunity. And the infection basically starts in the gut and is seen first by our bodies and our immune response for the first time in our gut. And some of these are neutralizing antibodies. So basically, my understanding is it sterilizes our gut in the sense that if we're exposed to polio again, we can fight that off and not let it into our bodies. And this will also decrease viral shedding once our immunity has kicked in. So in terms of the disease, poliovirus causes the disease we know as polio or poliomyelitis. And from the Greek, this actually means gray marrow. And that's because it's not in our bone marrow, but it affects the gray matter in the spinal cord. And it can affect anyone, but mostly children under the age of 5 years. They're the usual patients we see, but it can affect anyone of any age if they're unvaccinated or partially vaccinated. And actually 3/4 of people who acquire poliovirus infection are asymptomatic, but they can still transmit the virus. And then in terms of the symptomatic quarter of patients, there's an incubation period of about 7 to 10 days, but it can be as long as about a month. And it's sort of a non-specific illness, which if you get sicker, that would be regarded as the prodrome, but it might be all those patients, those people have. And this is what people also call, if they only have this part, the non-paralytic or abortive polio. And that's 95% of those symptomatic people. They will experience this prodromal illness, and this will be all they get. Although this in itself doesn't sound like fun. Headache, fatigue, myalgia, fever, nausea, vomiting, neck stiffness, and a pharyngitis. And then just a tiny little 1.25% of all patients, plus minus, will actually then get CNS involvement. So that's 5% of our symptomatic people will progress to some form of CNS involvement. So this apparently presents as almost like a biphasic illness, especially in children, where they would have had that prodromal non-specific phase, and then there might be a few days where they almost seem like they're better, and then they describe sudden severe symptoms where maybe they're actually just outside playing, although they're probably not feeling great, and then they're hit by this headache, fever, neck stiffness, and weakness. And if you were to do a lumbar puncture, which they may well have done, there would be cells in the CSF, but an aseptic meningitis. But it's more than just an aseptic meningitis. They can also develop polioencephalitis, which seems a little bit more severe. That can present with all kinds of altered mental status, even motor signs, but central motor signs or seizures. And then less than 1% of the patients who have symptoms will develop paralysis, which is then called paralytic polio. These people will experience profound weakness, which would be paresis or actual paralysis. They say the maximal loss occurs quite rapidly within 3 to 5 days, but it can sort of get worse even over a week. And then the most common type is spinal. So it's got a predilection for the anterior horn cells supplying the lower limbs. The weakness would be noted more proximally than distally in the legs. It's usually asymmetrical. There should be loss of reflexes, hence a flaccid paralysis. Sensory loss, besides the pain that seems to be this muscle pain that seems to be quite a prominent feature, that sensory loss is rare, and there might also be autonomic dysfunction. So it might look quite similar to Guillain-Barré, except for a few subtle differences, which is often quite difficult to pick up in children. And then you can get a bulbar type where there's a predilection for the nuclei of cranial nerves, trigeminal nerve, glossopharyngeal, and the accessory nerve. So they can present with tongue and neck weakness and difficulty breathing and eating. And then bulbospinal, where this I think is particularly rare but lethal, because it will affect the diaphragmatic, the motor neurons supplying the diaphragm. And 5 to 10% of those who have paralytic polio will die, and that would be from diaphragm or intercostal muscle paralysis. But there can be other complications, as you can imagine, if there's aspiration, pneumonia, or other things. So although we've gone down to saying that a very small number actually develop paralytic polio, when you have lots and lots of people infected, that's enough people with, other than just the mortality, severe morbidity that's going to affect people for the rest of their lives, and starting as children. And as you can see in this picture, really horrible disabilities result. And then the phases of paralytic polio are described as the acute phase, where they have the fever and the headache and the weakness. And then the recovery phase, where the recovery of some muscles begins, which is possibly compensation by the surviving neurons. But those neurons that have died, they're gone. And it can last for up to 2 years, this recovery phase, with the maximal improvement by 6 months. So probably if you haven't, it will only gradually improve thereafter if it's going to. And then the residual paralysis phase, where there's a variety depending on what was affected and how badly: imbalance of power, poor posture, leg length discrepancies, even bowel and bladder dysfunction with with urinary tract infections and ultimate renal failure. So 60% will have some residual deficit. So I didn't go into depth here, but I'll be honest, I don't think I'd ever even heard of post-polio syndrome. So as if it wasn't enough that that's all happened, anytime between 15 and 40 years later, survivors of polio, paralytic polio, 25 to 40% of these survivors can then get what's called post-polio syndrome, which I don't think is actually that easy to diagnose, especially if they had had polio and almost maybe forgotten it, or it had improved, or was maybe only mild. And then they become weak again. There's a variety of symptoms: muscle and joint weakness, pain that actually worsens over time with regular falling now. There's a general feeling of fatigue and exhaustion. Muscles become more atrophied, can even affect breathing and swallowing, sleep disorders, and interestingly, a decreased tolerance of cold temperatures. It seems to become static and generally progressive, with static periods in between. But it might be difficult to diagnose this, and it may look very much in adults like motor neuron disease. There are various ways of diagnosing it. And just this picture here on the proposed pathophysiology is that before one gets polio, you've got your normal axons and dendrites and things, and then polio directly affects the anterior horn cells, that dies, and then the others around there develop sort of extensions of their dendrites and try and compensate. But then almost overuse and atrophy from excessive use, they get tired and they wither away, and then it's almost like having polio all over again. And in looking up possible treatments for polio, the one time that maybe immunoglobulin could be effective would be in certain patients. They've shown, I don't think there've been any randomized trials, but they have found it to be possibly effective in some patients with this condition, if later inflammation is believed to be the cause. So the history of polio and some highlights in the story. It's an ancient disease, I guess, as many diseases are, but this has actually been depicted. It's been around for millennia, and there's a well-known stele from the 18th dynasty of ancient Egypt, many years ago, millennia ago, which clearly depicts a priest with a telltale paralysis and withering of his lower right leg and foot, and using a staff for support. So that would suggest polio. Then it grumbled along. People got it. Children got it, and they called it infantile paralysis. It seemed to happen now and then, and it maybe was just accepted as something some children get. In late 1700s, a pediatrician in London published the first clear description of paralytic disease of infants in a medical textbook, but it didn't get too much attention, from my understanding, until in the late 1800s, epidemics started to occur in countries of Europe and America. So Denmark, Norway, Sweden, in all the affluent, industrialized countries where stuff like that didn't necessarily happen. It's usually happening in the poorer countries. And so it hit the countries of Scandinavia, and then soon after that, Vermont in America. And this seemed vaguely ironic, well, very ironic, because these were industrialized countries and this was happening as there was the development and improvements in hygiene and sanitation. So why on earth was this happening now? At a time when things like cholera and typhoid were actually decreasing, obviously, with sanitation. They certainly did realize that these outbreaks and epidemics appeared to have a contagious element. And they started to realize that these epidemics would occur almost every year in summer. So it struck fear into everyone, obviously, particularly parents, knowing that this summer your child could end up paralyzed or demise. And so actually they went down into almost what we now know as COVID lockdown conditions. They weren't allowed large gatherings. Swimming pools were closed because well, possibly children defecate in pools, but certainly there's a more mixing of fluids in pools and gathering of people, and certainly children go to that area now. Whether they were worried that children were the vectors or it was children who got it, they wanted to protect their children and keep them away, and children weren't allowed at cinemas. And the theory as to why this happened is that previously, over all those years and millennia, everyone was exposed at a very young age. And because everyone had probably had polio, the maternal antibodies were probably present in everyone. They'd either had an asymptomatic or a mild infection. So there were maternal antibodies that went into, were in utero, transferred to the baby, and also via breast milk. And so if they encountered, when they encountered polio at a young age, it might have caused a very mild illness, and then the babies would produce their own immunity. And then with hygiene improvements, it led to an exposure at an older age of these large groups, cohorts of non-immune children, and then they would all be affected. And that led to these epidemics, which were mostly in children, but certainly occasionally in adults, but not epidemics, 1 or 2 adults for all the numbers of children that would be affected. And it also seemed that these children developed a more severe type of disease when they were a little older. And then obviously, because this wasn't a developing or third world country, this was an affluent disease, it seemed. I mean, it was also happening everywhere, but because it was happening in these affluent countries, that really disturbed people. And they obviously also had the money to spend to try and see what was causing this and develop a vaccine as soon as possible. So important people in the polio story. Jonas Salk was he basically, from my understanding, became quite a celebrity, but not necessarily loved by his peers. I'm not sure, but he became famous for what he did, and we know it as the Salk and the Sabin, I'm not sure I'm saying his name right, vaccines. And he developed the inactivated injectable polio vaccine, which became licensed for use in 1955 after he had done lots of testing and huge trials. It was deemed to be safe and effective, and he became a world-renowned celebrity because what he did changed people's lives. Apparently he was a reluctant celebrity, but he was a celebrity nonetheless. Also, when asked, was he going to patent the vaccine, he said, no, the vaccine belongs to the people. Could you patent the sun? Something like that. So that was one of his famous quotes. So he seemed to be a very decent man. But actually, it turned out he wouldn't have been allowed to patent it because it wasn't all his own original work. The groundwork was laid by John Enders actually before him, with Weller and Robbins, who cultured poliovirus. So he couldn't have done what he did if they hadn't cultured the poliovirus in 1949, for which they actually received the Nobel Prize for Medicine or Physiology in 1954. And then there was Albert Sabin, and he developed the live attenuated oral polio vaccine a few years later. And because of various reasons, it was tested on and given to 77 million children in the Soviet Union, and found to be effective and safe, and then licensed in 1961. So just, there's a lot of famous people, if you look it up, who had polio. Alan Alda from MASH, Mia Farrow. I wondered if Forrest Gump, I'm aware he's not real, but I wondered whether his calipers were actually put on him because of a form of polio he might have had. This is someone called Wilma. Now I've forgotten her name, and she was an Olympic runner, and she'd survived polio from a young age, and actually turned out to be a record-breaking Olympic. Wilma Rudolph, an Olympic sprinter, and Donald Sutherland. And then another big name, and I think if you look anywhere into the history of polio, he's gonna come up. Franklin D. Roosevelt, and he had polio at the age of 39 years in 1921. Apparently, he tried to hide it from the public eye for many years. He didn't want to be seen as weak or sickly, but he did actually require a wheelchair. And so there's pictures circling where he's subtly trying to lean on his wife and lean on the railing there because he was weakened. But so he definitely suffered the consequence of polio. But the good thing that came out of this led to the establishment of the National Foundation for Infantile Paralysis, which became known as the March of Dimes. He set this up and asked all Americans to post dimes, 10 cents, as many as they wanted, to the White House to raise money for funds for research. And this helped to pioneer the vaccine research. And he also sorted that it funded rehabilitation centers for polio victims. And because of all of this, it is his name on the US dime. And then other hallmarks of the polio era, if you've seen these, you think of polio. If you think of polio, you might picture these images. But I don't think I've never actually stopped to think about, children would stay in hospital for months on end. It must have been hideous. They were put into splints, plaster casts to prevent contractures and to allow the muscles essentially to rest. But this did actually just lead to more atrophy. They were put into boots, calipers, and braces to support the limbs. There were also archaic-looking exercise chairs. And this was a painful disease, and the rehabilitation was agonizing. And then I don't think many people got away with having had polio without having some sort of surgery, if not on the affected limb, but then actually on the unaffected limbs as well, because that was now going to be growing, and they had to cut the growth plates or do something to the growth plates so that there wasn't this leg discrepancy. But while there was, they had these built-up boots. And so many people who've had polio, I think, have had more than one surgery to their legs. And I think just to remember that this wasn't only happening in the Western countries. Children across the world suffer the consequence of polio. And obviously, many have even more severe challenges and much fewer resources. So I think a pair of crutches is all they can get. And we must consider that some live far away from even a road to get to a village, So it's really a difficult disease to live with for many. There's also images and pictures of wards filled with children in what were called iron lungs. This was something that is almost synonymous with polio. It was invented by Drinker and Shaw actually in 1928, initially for coal gas poisoning, but then widely used in the 1940s and 50s for polio patients. So there would be wards full of these coffin-like machines with little babies' heads and children's heads sticking out. And they were negative. It's a negative pressure ventilator, which would pump air out to create a vacuum inside, which would expand the chest and pull the diaphragm down, draw air into the lungs, and then the air would be forced out. This is mostly children who would be on these because they were the ones affected, and they generally they might die pretty soon, but if they were going to survive, they would be in the iron lung for about 2 weeks. But some ended up requiring lifelong ventilation. And I mean, this scene is reminiscent of the horror of COVID wards, only probably a little more terrifying with these machines and, you know, all these children. Then there was this man who's the longest surviving iron lung polio warrior. I didn't want to call him a polio victim or patient. He's quite amazing. He lived in an iron lung for 70 years to the age of 78, and he died during the COVID pandemic, probably from COVID. It doesn't seem like they're certain. In that time, he qualified as a lawyer. He became an author, and he was, if you look him up, he was an active TikToker. I also thought it was quite funny the way this machine came from the 1940s or 50s, but he sort of pumped it up a little bit with screens. And there's another page who also had a TV and a flat screen and everything. And this man could paint with his mouth and do all sorts of things. And apparently one of the big challenges was sourcing a replacement parts if anything broke, because they don't make them anymore. And also power outages meant no breathing, so wouldn't really cope with ESCOM. And then other pictures, genuinely, this was from the time homeschooling during the time of polio, and various attractions and cinemas, things like that, where it said polio and things were closed. So this reminds us of COVID. Some treatment that certainly didn't cure, but actually helped, because there's no curative treatment. It was physical therapy, introduced by someone called Elizabeth Kenny in Australia, who was a self-trained nurse in the 1930s, who prescribed hot, moist packs to the muscles with massage, exercise, and early activity to try to maximize strength of the unaffected muscles and stimulate the remaining nerve cells. And she started a rehabilitation institution in America as well. And actually, this is still accepted treatment, still used today. So what is the solution? Well, it's obviously the vaccine, well, the vaccines, because there's the two. So the Salk vaccine contained three wild virulence, the three wild virulence strains, and Jonas Salk grew the virus in monkey kidney cells, which he then inactivated in formalin. It cannot cause polio. It's injected. And essentially what it does very well is induce humoral immunity, which is IgG, and prevents the viremia. So the person can still ingest the polio virus. It can still do its thing in the gut, but it cannot get in and cause a viremia, and therefore it cannot get to the neurological system, the CNS, and produce the paralysis. It can produce some mucosal immunity, but I think that cannot be depended upon. So it protects the recipient, but doesn't prevent person-to-person spread. The virus can still go through that person's body into the wastewater and be spread. In 1952, he produced it, and then it was licensed in 1955, and then they started these massive vaccine campaigns, and numbers plummeted in America from in the thousands, tens of thousands in 1953 to just 161 in 1961. And now it's combined with various combinations of other vaccines to be given. One thing happened that was pretty disastrous, called the Cutter incident, and that was in April 1955. Because he didn't patent it, any company could then make it, and the one company, the Cutter Pharmaceuticals, they didn't fully inactivate the live virus. Whether they knew that or not, I'm not sure, because they said they didn't disclose it, but more than 200,000 children in various states in the US received this tainted, well, actually live polio vaccine. And at least 220,000 people were infected with the live virus because contacts also got it. And 70,000 developed muscle weakness, 164 were severely paralyzed, and 10 died. In a good way, it did lead to much more stringent quality control processes in the future, but I mean, one can definitely understand why this might contribute to some vaccine mistrust and hesitancy. And then the oral polio vaccine is the live attenuated virus. It's attenuated or weakened by passage of virus in non-human cells at subphysiological temperature, which produces spontaneous mutations, which make it not virulent. And the nucleotide substitutions prevent replication in neural tissue. It can still replicate in the gut of the recipient and shed for up to 6 weeks in the stool. So in 1963, they licensed the trivalent oral polio vaccine, and that then became the vaccine of choice in the USA and most of the world. And it replaced the inactive vaccine for many decades until 2000, when USA went back to the IPV. And so after this, then now there was a second wave of mass immunizations in the USA, and it did take them all a little longer to recognize that polio was actually causing some problems in developing countries as well. So then in the 1970s, they started routine national immunization programs in the rest of the world. And the Global Polio Eradication Program or Initiative was established in 1988, and the goal was to eradicate polio by 2000. This picture here is of sugar cubes. So they could just put the drops in the mouths, but they actually, it was so easy to give, they gave it in little cubes of sugar that the child could then take, because children would love that. I may not say it another time, but okay, no, I'll still come to that. So this was, why would you want, how do you think you can eradicate a disease? You have to have certain preconditions to say this disease can be eradicated. The agent can only infect humans, tick for polio. There cannot be a non-human reservoir. That applies to polio. The infection must induce lifelong immunity. That applies. There must be a tool or intervention that effectively interrupts the chain of transmission from one to another, and that's the oral polio vaccine. There must be political commitment in the form of sufficient human and financial resources to carry the initiative from beginning to end. And I think there's many organizations who are extremely committed, but the people have caused so many problems in actually carrying this out. And yeah, people, certain groups of people. And then the burden of disease must be considered of great public health importance with broad international impact, which definitely apply to polio. So now to just ask ourselves, what's the big differences between the oral versus injectable polio vaccine? So we can understand what was good and bad about them. So the oral was the live attenuated, and what's great is that it's easy to administer, and when you have to do mass immunizations, then anyone can actually give it. You just need someone to be able to drop 1 to 2 drops in every child's mouth, and that's done. And I remember learning about the vaccination, mass immunization campaigns as a medical student, and Prof was a reg, and Prof Saluji said they just go around to the streets, to the clinics, to people's houses, and they just put some drops in children's mouths. And he said they caught more children than rats that day. I'll never forget that. Just children everywhere, open mouths, put the drops in. It's also good because it produces probably lifelong immunity with this good mucosal immunity, which means it stops person-to-person transmission. And what's good is it's excreted from the intestine for a few weeks, which is good in endemic settings where not everyone might be vaccinated, because then it passes through this person, gives them the immunization, and also gets to other people who might not have made it to get their drops. And yeah, if it's in the contaminating water. So this is preferred for the Global Polio Eradication Initiative. It's just much easier to do. It's cheap. I saw different price, but about 20 US cents, and it's effective. It's a small con, but it's important that there's a small risk of vaccine-associated paralytic polio, which numbers vary, but they seem to say about 1 in 2.7 million doses, and a higher risk if you have an immunodeficiency, specifically certain ones like A-gamma-globulinemia. And then it can also start to circulate and persist in under-vaccinated populations and produce circulating vaccine-derived polio virus, which can then cause paralytic polio, just like the wild virus. So I had to create this for myself to understand. If you give this person at the top, you give him or her their oral polio vaccine in a population that's relatively well vaccinated, you've got the green faces are already vaccinated, the reds aren't. So if his oral polio virus gets into the water and gets in contact with the vaccinated people, it won't do anything, bounces right off them, doesn't cause a problem, and it goes to the few in the community who aren't yet vaccinated, and it essentially vaccinates them. So that's fantastic. But if there's an under-vaccinated region, let's say he gets the vaccine the oral vaccine, this person had the vaccine, but so many of them didn't have it. So it goes from one to the other, passing it on and maybe vaccinating them on the way. But after up to 18 months, they say, this virus starts to proliferate and replicate, and the necessary number of mutations can occur till eventually that circulating vaccine-derived poliovirus is a mutant and it's regained its virulence. And so now we got some who were vaccinated via that initial person, but now you've got this mutant which can now cause actual poliovirus. So it reverts back to virulence. So in terms of, so in terms of the injectable inactivated vaccine, it produces that good humoral immunity, which prevents viremia and CNS infection. And after 3 doses, for sure, they are essentially immune to paralytic polio. They can still get a bit of a gastrointestinal illness, but they're immune to paralytic polio. I put a lot of cons because I find myself being more on the side of the oral polio vaccine. So there is less mucosal protection, and I see it as it's a selfish vaccine. It protects that person, but no one else. So the person who's had it will not get polio, but they can still transmit the virus if they ingest polio. So it's not helping to eradicate polio. It protects the recipient only. It is significantly more expensive, which is obviously a problem in more low middle income countries. You need the cost of the vaccine itself is more expensive, and then there's needles, syringes. If you think about needle hazards, you require someone who's skilled, trained at administering injections. Obviously more time consuming, and the immunity does wane a bit, and boosters may be needed. So they both, after 3 doses, are almost, above 95% of people will have seroconverted. So they're both effective. So some fears about the oral polio vaccine, and these are realistic fears. Like I mentioned, vaccine-associated paralytic polio. So that can be just because of bad luck. Someone can get the oral polio vaccine and it manages to replicate, and one little mutation even can happen. But if it's in the virulence determining region, that can quite quickly turn into polio, the virulent form that can now get into the body and cause CNS disease. And then there's actually also a much higher chance if the person has a genetic or other severe immunodeficiency. But in those patients, it can actually take months of replication. They just remain shedding this virus, it's replicating in the gut, and eventually it mutates. And sometimes this is actually the first sign that this person has an immunodeficiency. And this is called immunodeficiency-related vaccine-derived polio. And they can spread that. And then the big concern is really the circulating vaccine-derived poliovirus, which we said is when you have insufficient vaccine coverage. So big, overcrowded sort of population, lots of people living together, but only not enough are vaccinated. So the ones who are transmitting this virus, and it's moving from person to person. And then they also talk about ambiguous vaccine-derived polio vaccine cases where they're not sure where this one came from. I'm not going to go into that because I can't. So it seems that some combination with OPV and IPV is advisable, because then you would be protected and you're protecting others. And the ideal is to achieve at least 95% coverage. So the unfounded fears about the polio vaccine are, and this is what is causing problems with managing to vaccinate everyone in the world, is that certain militant religious groups in Nigeria as well as Afghanistan believe the vaccine contains forbidden haram ingredients, and that the people of the West are attempting to cause sterility in the males. The Taliban actually has tried to has managed to stop vaccination campaigns. So they opposed to house-to-house vaccinations. And one of the big reasons is that women are responsible for this, and women are restricted from doing this. And this is despite the support of the vaccines by the government. So it's only certain groups of people. And there's also emphasis on the importance of vaccination by Muslim organizations. And there are other religious groups in parts of the world that have also stated that their religion doesn't allow vaccines. And again, their people high up in their religion say that really isn't true. They're all pro-vaccination. And then obviously there's many areas which are simply underserved and difficult to reach. People living far out, people who cannot get to clinics, and people don't get to them to give it. There's displacement, natural disasters, and war. So ideally, as I understand it, the idea would be to phase out the oral polio vaccine at some point. So the wild-type poliovirus 2 was last detected in 1999, and they declared it eradicated in 2015. The wild-type poliovirus 3 was also declared eradicated on World Polio Day in 2019. So they actually decided to remove wild poliovirus 2 from the trivalent vaccine, and so now it's only a bivalent. But the problem was then they discovered that there was circulating vaccine-derived poliovirus 2 already in circulation. And now it can cause cases because we're not protecting against poliovirus 2. And now there can be cases and actual outbreaks of polio. And in 2017, the vaccine-derived poliovirus cases outnumbered the wild-type virus. So we almost have won against the wild-type, but now we've got the problem of the vaccine-derived polio. So the big dilemma would be, well, my question is, and I think it's a valid question for the clever people to figure out, are they supposed to add it back, or are they still trying to phase it out? But you can't ignore the fact that there's circulating virus now. So it's essential to maintain effective surveillance so that when they detect a certain virus in a certain serotype, then they have these mass campaigns and they say 2 to 3 doses, especially if you find the CVD-PV2, then you go and give all the people in that area, certainly all the children, OPV2, 2 to 3 doses, and it nips it in the bud. So now they're actually using a novel OPV2, which genetically is supposed to be more resistant to mutations to become a virulent form, but even that isn't 100% foolproof. And that was licensed in 2023, and they're working, as far as I know, on a novel OPV1 and 3. Just a quick graph to show how the numbers plummeted with the introduction of the vaccines. I mean, it's already been introduced there, and wild type decreased, but then the vaccine-derived cases started to grumble along. They certainly aren't creating the epidemics as like the 35,000 kind of numbers, but they are there. So where are we today? Is polio a thing of the past? Just to say, I'm not going to dwell on all of them, but many countries, most countries, are polio-free or deemed eliminated long ago. So there are different terms, but you have to be free of polio for a certain time to be certified as polio-free. And Nigeria is free of polio in 2020, but there is still transmission of the vaccine-derived polio. And as I mentioned before, so what happened in Gaza, there haven't been cases found for 25 years. But then this year in 2024, 6 environmental samples of wastewater were found to be positive for circulating vaccine-derived poliovirus 2, followed by 4 clinical cases of acute flaccid paralysis with 1 confirmed case of that virus in a child. And their response, which seemed almost impossible, but when they put their mind to it, they really managed. I think they surpassed their expectations. Over 187,000 children under 10 years of age were vaccinated with a novel oral poliovirus type 2 in central Gaza during the first phase, but they're going to do another round. They have done another round. Yeah, and it's just because that luckily is so easy, but you need people getting in there, obviously, to these war-torn areas. Okay, so what about South Africa? Our last case of wild-type poliovirus was in 1989, but we are still at risk of new cases of wild or vaccine-derived polio because we have people coming into the country all the time, and they coming from regions possibly bringing polio in, and we also have regions of under-vaccination and inadequate surveillance. So we have about 75 to 80% vaccine coverage, which isn't optimal. And we often have shortages. We see this when we look at our kids' road to health cards. There's often an oral polio vaccine that hasn't been given. Or people don't get their vaccines or they were turned away because the child had a fever. And certainly COVID interfered with vaccinations and surveillance activities, which are crucial. So for now, we are giving birth drops, oral poliovirus drops, if vaccine drops when we have it, which is usually. Then at 6 weeks, there's an oral poliovirus with IPV, and that's combined with some others at 16 and 14 weeks, and then at 18 months, they get another injectable polio vaccine. So just using colors to show where it's still endemic, and that's Pakistan and Afghanistan, and the countries who the dark blue were long ago they had their last recorded wild paralytic polio case. So what happens in the developed world? Their schedule is basically they only use injectable poliovirus. That's a vaccine of choice since 2000 in America. And they consider that the risk of vaccine-derived poliovirus from the oral polio vaccine is greater than the chance of someone bringing a wild polio case in. But for it to actually be 100% effective, you need 100% coverage. Otherwise, you get these groups of people where they have no immunity. And the big problem with a lot of people having the IPV coverage is that you can have the silent, sort of silent epidemic almost, that you don't know, silent transmission. They don't show the disease because they're protected, but they are passing it around. And then it gets to a population who has no vaccination and they will get polio. So that's silent transmission. So ultimately, they're going to be sporadic cases, outbreaks, and still with the IPV, if you've got a case coming in, you're not going to eradicate polio. So they give at birth between, the first dose around 1 to 2 months, and then at 4 months, somewhere between 6 to 18 months, and a booster at 4 to 6 years, and then some might even add on a 5th dose in adolescence. The schedule recommended by the WHO in endemic areas, and this is essentially Pakistan and Afghanistan, they recommend a birth OPV and then 3 more OPV doses 4 weeks apart, and then 1 or more IPV doses after 6 weeks of age. Problem is, this is what they're suggesting, but that's not what's happening, and that is why these are still endemic areas. But that's, if they're able to achieve this, that might definitely make a difference. And then there's the countries which there's more than 90% vaccine coverage, but they're not really on the USA level. So they talk about 1 to 2 doses of IPV and 2 doses of oral, and the USA only uses IPV. So there's just a depiction of the countries which use IPV and oral. And then America, some parts of South America, Europe, Australia are only using IPV. And also areas where the share of 1-year-olds are vaccinated against polio. So Russia, there's high numbers of vaccination of 1-year-olds, which is quite impressive, and we are somewhere around 80%. So to me, the take-home message is that oral vaccine breaks transmission, and we need that to happen. The IPV protects the individual, which we would also like to happen because we don't want people getting paralytic polio. So to me, it makes sense that a combination of both is ideal unless if we don't have 100% coverage with other vaccines. And apparently it's probably better if they get a dose of IPV first, because that primes the immunity so that when they get that first oral polio vaccine dose, it has no chance of causing paralytic polio in them if they're 1 in 2.7 million who is that unlucky. So they first got that IPV dose and then some oral. But IPV alone is fine if everyone is immunized. And OPV is good for mass coverage when environmental polio, or they find a case or they find in the environment and they need to do a quick mass campaign. But the problem with OPV, it still has the chance of vaccine-associated polio and the perpetuation of variants. Again, you could avoid this if we got 100% uptake. So therefore, we ideally want to eventually stop it. So what can we do? We being doctors, I'm speaking as clinicians, I guess. We need to play our part in surveillance. So any acute flaccid paralysis, we need to notify and send that stool. We need to get our patients and our children immunized and caught up, even if not for themselves, for the community and the greater good. So I was wanting to know, you know, when we do see this OPV is missing, this baby missed their oral polio vaccine at birth, does this matter? It technically doesn't matter for that baby, but it matters for that baby's family, where that baby, if they're exposed to polio, they could then spread it. And, you know, the community. So it should still be caught up. And then I just reckon it's too complicated. So we just need to listen to what the very clever people tell us at the NICD, at a thing I heard about today from Dr. Kerrigan McCarthy, when she gave me about an hour-long tutorial on the phone. It's a National Advisory Group on Immunization, and then the WHO. So these people are very busy with very fancy epidemiological stuff and surveillance and deciding what goes into what vaccine and who gets what and how things must change. That's just to talk about, yeah, surveillance. And then as long as there are endemic areas where transmission is uninterrupted, the world is going to be at risk. So even if you've got this nice little country you've decided is free of polio, if there's importation of polio somehow to a polio-free area, and there might be weak public health or immunization services or just stubborn people who haven't been vaccinated with travel, you're going to get polio reintroduced and circulating again. And then this is just a picture of all the areas. So the light blue is areas that are polio-free, the 2 countries that are still endemic, and then polio-free but not yet certified. And then that's it. Thank you. And Polio Day is on the 24th of October. So have a good day and put some drops in the child's mouth.
Thanks, Judy. Really nice overview. And yeah, it gets very complex towards the end, just as you're busy trying to eradicate it. I've posted a message from Prof. Bloomberg in the chat too, who continued your theme of P alliterations. I'm just making sure to recognize the role of the Rotary International and polio response as well. Big partner, she says, with Gates and others, WHO. Questions in the chat as well were about, well, one of them was from Lauren saying, do you know if any polio is circulating in South Africa in like wastewater, for example?
Sorry, I wish I could say I've checked lately if there's any circulating. As far as I know, I don't think so currently. But I stand to be corrected. And I spoke
so
to
I think there's occasional
office.
detection of the Sabin strains, derived strains in the wastewater. They do now do surveillance for it. It's quite sporadic. Obviously, it's not in high volume.
Not circulating. Well, found
it's wastewater. So,
yes.
so some of it's going around, but I think it's quite low. I mean, again, others on the call may know more. If you do, just stick up your hand. I'll unmute you. But this, Lucille says no to wild recent circulating of wild type polio in Mozambique. Yeah, but I think the vaccine derived strains, there is a little bit of detection form, which you'd expect occasionally, right? I mean, that's what happens with the vaccinations. Okay.
But as far as I know, I just have to, so I think you definitely are, from what I understand, you want to find the vaccine, the actual vaccine virus in wastewater. That's fine. That's almost the intention. Yes. But you don't want to find these variants, the vaccine-derived polioviruses, because they have the mutations.
Sorry, yeah, I should have been clearer. Yeah, exactly right. And then I've got a comment from Galaxy A5 5G. So I've made you co-host if you want to unmute, but whoever it was talking is saying just submitted a paper on 3 cases of post-polio syndrome in South Africa. The oldest patient is 101 years old. So people may not be familiar with post-polio syndrome. Do you want to mention anything, or otherwise, I don't want to put you on the spot, but you may be in an area where you want to.
I assume you're talking to the person who wrote that, not me.
Yes.
Oh, okay.
So
hi, Jeremy. Yes, ours here. We've just submitted one. Jeremy, can you hear me?
Yes, I got you. Hi, carry on.
Yeah. It's just that it presented here at our hospital at Brenter's Clinic. We have 3 cases, And the one case is the oldest survivor of polio in the world. We've checked. He's 101 years old. Yeah, and we're describing the case. We've submitted it to the British Journal of Clinical Medicine.
Nice. So yeah, so for those who don't know, the post-polio syndrome is where you get new or worsening symptoms, but years after the acute thing. So it's a sort of late onset secondary weakness. Really fascinating. Yeah. Okay, so we'll look out for that. That's fantastic. And then Tom's making the good point about to maintain the polio-free status, the country has to report a certain number of acute flaccid paralysis cases per population. And at one point, South Africa did, to drop below that threshold. And it is a reminder. I mean, I know, Judy, you guys in PEDS are actually to do most of it, obviously. But that is obviously, it's an ongoing need to report these cases and to investigate them, even if you think there's a better course, even if it is likely to be number A.
Yes.
Cool. I'm just looking through. I think we've caught the comments in the chat. Yeah, so the final push, last two endemic countries, but those have been quite stubborn there. I mean, you mentioned the issue. I mean, one of the problems in Pakistan for a while was when, in the effort to capture Osama bin Laden, the CIA developed a sort of fake polio campaign to try and find family members effectively from blood samples. And that set it back in Pakistan a huge amount. And I know that since then they've publicly stated they won't ever use vaccine programs as sort of, as a military tool anymore. But it just shows, as you said, about the sort of these unintended consequences of the politics around, very difficult areas in the world, obviously, in some of these regions, and how it can blow back.